doctors. A very warm welcome to all of you on behalf of Dr. Bhatia's Medical Coaching Institute and eGurukul, the Inspired Learning app. Myself, Dr. Vaidehi Desai Shah, consultant robotic gynecologic surgeon and an obstetrician and your mentor for obstetrics and gynecology. So today I have come up with a very important clinical case which we commonly encounter in our labor rooms and our OPDs. And this is hypertension in pregnancy. Hypertension in pregnancy is one of the most common causes of maternal mortality, leading to the deaths, maternal deaths at a very early as well as at a very later age. Remember that it is one of the most common causes of maternal mortality coming after hemorrhage and infection. So this is something very, very important, and that is why I have come up with the discussion of this clinical case scenario. So this is how our case goes like. So our patient is Mrs. Arena. I have changed the name of the patient to protect the security and the privacy of the patient. So she is Mrs. Arena, a 28 years old female, a primary gravida at 33 weeks and 0 days of gestation, who came to antenatal clinic for a routine obstetric checkup. She is a homemaker who lives in a small town and is a non-smoker, belonging to lower middle socio-economic class, having no special habits. Her husband is a salesman, a non-smoker, non-alcoholic, and works for a local company. Remember that the personal history of any patient and her partner is very, very important whenever we discuss any case, because so many clues will pertinent to the case will be picked up from the history itself. Remember that the history gives 80% of the diagnosis, and history combined with the physical examination owes to around 95% of the diagnosis of your case. That is why a detailed history and physical examination is very, very important for any clinician. So this patient, what brought the patient to the hospital? So when we took the history of the patient came up with chief complaint of cessation of menstruation since 8 months. Remember that whenever a patient reports amenorrhea, the patient would always report amenorrhea in terms of months of gestation rather than the weeks of gestation. This patient had severe persistent headache and blurring of vision since 1 day, and this brought the patient to our OPD. So this is the chief complaint of the patient which brought the patient to the to seek our gynecologic consultation, right? All right. So a history of the presenting illness begins with the type of the complaints. When did certain kind of complaints of the patient start, right? For example, here in this case, she had headaches. So when we asked about the headaches previously, she would report as she had occasional mild headaches lasting for a short duration only, occurring once in a month since past 1 month. So that comes about only 4 episodes in a month, which were relieved with analgesics. But since past 1 day, she had onset of severe headache, which was diffusely located, which was throbbing in nature and was not relieved with analgesics. There was also associated blurring of vision since 1 day. So it is basically because of the severity of the headache and the blurring of vision that the patient sought consultation. So remember that whenever we report any headache, we always report it in terms of its severity, location, nature of the headache, and the aggravating and the relieving factors. So as the patient is reported, it was not relieved with analgesics. Each and every word which has been mentioned here has got clinical significance. It will help us to rule in and rule out the other differential diagnosis. So hold on for a second, hold on for like 5 minutes, you will get to know what I want to pinpoint, right? So when we took the history of the patient, we also ask about the obstetric history of the patient. Remember that this is an obstetric case, and that is why obstetric history is very, very important. She is a primary gravida, meaning to say she has conceived for the first time ever. Her obstetric score is gravida 1 para 0. There was no history of any ectopic or molar pregnancies. And when we ask the patient whether she has conceived it naturally, I mean spontaneously, the patient says yes. That means the present pregnancy is a spontaneous conception. There is no history of any infertility or ART treatment prior to pregnancy. Remember that any sort of infertility treatment like ART, IVF, IUI, they are all considered as risk factors for developing hypertension in pregnancy. So that is why this history is very, very important. But luckily in our patient, it was a spontaneous conception. Her last menstrual period was 19th of September 2020. Her expected date of delivery is 26th of June 2021. And when the patient came to us at our OPD, her gestational age was 33 weeks and 0 days. So now we have this patient who is at 33 weeks and 0 days of her gestation. She had routinely come for antenatal checkup and had normal course of pregnancy in all her previous trimesters. Meaning to say this is a compliant patient and she has routinely come up for antenatal checkup. She has taken 2 doses of tetanus immunization. She has undergone regular ultrasonographic evaluations as recommended by her gynecologist, that is our department, and no anomalies were noted on her scans, right? So, but there is one significant finding which we had observed, which I would like to show you. I have attached one ultrasonographic report of her USG scan for her, done at 25 weeks. So this is the sonography Doppler. Okay, this is the Doppler of the uterine artery. There is one abnormal finding over here which I want you to observe. If you note this arrow, you would notice, so this are the 2 waves basically. That is an upward peak and that is a small peak, right? So this upward peak is known as the peak systolic velocity, okay, peak systolic flow. So this is the blood flow in the uterine arteries when there is systole. And that is the blood flow to the uterine arteries during diastole, which is shown by the smaller mountain. But there is a notching which is represented by the arrow, which is seen during the diastolic phase. So this is known as the diastolic notch in the uterine arteries. Remember that after 24 weeks, whenever there is persistence of diastolic flow in the uterine arteries, it is considered as a sign of high resistance. It is considered as a sign of high resistance to the blood flow, and this may be associated with development of pathologies like preeclampsia, fetal growth restriction during the later part of pregnancy. So this is known as the diastolic notch, and it was reported at around 25 weeks of gestation. And because it was considered to be as at a risk pregnancy, we had started her with low dose of aspirin. Okay, so we had started her with low dose of aspirin because whenever we have such diastolic notch, we should start with aspirin according to the latest guidelines by ECOG. Remember that it can be started as early as 12 weeks and as later as 28 weeks according to latest ECOG guidelines. And optimally, it should be started before 16 weeks. But because this patient had come to us and this diastolic notching was observed at 25 weeks, still we started her on low dose aspirin, that is around 81 milligrams, right? So 75 milligram to 100 milligram is considered as low dose aspirin prophylaxis. So even the dose recommended by ECOG is 81 milligrams. So any range from 75 to 100 is considered as an appropriate dose. So we had started her with low dose aspirin so that complications can be prevented. But as we all know, it has been quite a bit late for her, right? So when we ask about the medical and surgical history, so the past medical and the surgical history of the patient reveals that she had no history of hypertension preceding pregnancy. By this, we are ruling out the presence of chronic hypertension. So she was not a known hypertensive case. It was just that she had this problems only now, right? There was no history of pre-gestational or gestational diabetes mellitus. Remember that diabetes mellitus, whether it is gestational or pre-gestational, is considered to be a risk factor for developing hypertension. There was no history of vascular connective tissue disorder like SLE, systemic lupus erythematosus, no history of autoimmune diseases like antiphospholipid antibody syndrome, no history of thrombophilias. Remember that all of them are considered to be a risk factor for preeclampsia, but our patient had no such risk factors, right? In the review of systems, in the constitutional signs and symptoms, she had just mild fatigue, which is also common in pregnancy. It was nothing much severe about that. She had no fever, no chills. In the hint, she had headaches and blurring of vision. In the respiratory system, there was no shortness of breath, no cough, and no hemoptysis. By this, we are ruling out that there are no symptoms of pulmonary edema. Cardiac system was negative for chest pain, orthopnea, and palpitations. So we are ruling out any heart disease. The gastrointestinal system was negative for abdominal pain, change in bowel habits, and nausea, vomiting. Genitourinary systems were negative for dysuria, frequency, hematuria, frothy urine. Musculoskeletal system was negative for pedal edema, arthralgia, back pain, and skin had no rashes, no bruises, right? So, if we look at the physical examination of the patient, the vitals of the patient were quite stable. So she was basically febrile. Her heart rate was 82 beats per minute. Blood pressure was 146 by 92 millimeters of mercury, and then 142 by 90 millimeters of mercury measured at right arm in the sitting position. Remember that in pregnancy, the right arm in sitting position is considered to be an ideal way of measuring the blood pressure. And this were the two occasions when blood pressure was measured, and this was 4 hours apart. That is why I have mentioned 2 BP findings. Respiratory rate was 16 beats per minute. SpO2 is 100% on room N. On a general examination, the patient is conscious, coherent, cooperative, pleasant, comfortable, and well-oriented in time, place, and person. Hint showed pink palpable conjunctiva and sclera, moist mucous membranes. CVS had normal heart sounds with or the normal flow murmur over left lower sternal border. Pulmonary showed bilaterally clear breath sounds, no wheezing, no crackles. In the abdominal examination, the patient was pregnant, so she was having a gravid abdomen, which was soft and non-tender. The obstetric examination reveals that there was symphysiofundal height of about 33 centimeters, which corresponded to the uterine size of around 33 weeks. So there was a single live intrauterine fetus, which was longitudinal in its line, cephalic in its presentation, and the fetal heart rate was 46 beats per minute. So these are all normal obstetric examination findings. Extremities where she had normal extremities, no edema was noted. This is very, very important because usually in patients with hypertension, extremities would have edema. So because of the proteinuria, right? But this is a different case in which no edema was noted, even in the patient of hypertension. So we will label this patient to be a case of hypertension. Why? Because the blood pressure is more than or equal to 140 by 90 on 2 separate occasions, which are 4 hours apart, right? So this is purely a case of hypertension. Now let us see what these were the laboratory investigations. In the laboratory investigations, the CBC was normal. Platelets were also normal. RFTs, that is renal function tests, were normal. Liver function tests were also normal. Urinalysis was normal. There was normal. There was no proteinuria in even in the urinalysis, right? So urine protein to creatinine ratio was also normal. So in nutshell, I would like to say that everything was normal on the examination, whatever we had done, except headaches, blurring of vision, and hypertension. So what are the salient features of our case? The salient features are that she has a gestational age of 33 weeks and 0 days. Point 1. Positive findings, pertinent positive findings that we have are hypertension, headache, and blurring of vision. All right. And what are the pertinent negative findings in our case? That is no proteinuria, no shortness of breath, no cough, no hemoptysis. So no proteinuria. So by this we are ruling out the kidney problems, right? The chronic kidney diseases are ruled out. No shortness of breath, no cough, no hemoptysis. We are ruling out pulmonary edema. No abdominal pain. We are also ruling out GI as well as liver problems, right? No pedal edema, no dysuria, no frequency, no hematuria, no frothy urine. Okay, so these are the pertinent clinical findings, pertinent negative findings that we have in our case. So based on this, what is a differential diagnosis? So you have three different main symptoms which we have here in our case. And the three main symptoms are hypertension, headache, and visual symptoms. So based on this, we can narrow down our differentials to this particular group. So for the differentials for hypertension are gestational hypertension, preeclampsia, chronic hypertension, and superimposed preeclampsia. For headaches, we have differentials like preeclampsia, eclampsia, migraine, headache, tension headache, cluster headache, press is posterior reversible encephalopathy syndrome, meningitis, and subarachnoid hemorrhage. In visual symptoms, we have the differentials of preeclampsia, eclampsia, press, CSR, that is central serous retinopathy, diabetic retinopathy, benign intracranial hypertension, and high myopia. All right, so these are the symptoms that we have in our differentials. Now, if we want to come to diagnosis, we need to rule out the other differentials. Like for example, if we look at the nature of the headache, a patient had a diffuse, throbbing, severe headache, which was not relieved with analgesics. So if we look at the tension headaches, cluster headaches, they have got a typical pattern of headache. In migraine, the headache is unilateral. Okay, so but in our patient, the headache is diffuse. So we are ruling out these differentials. When we talk about subarachnoid hemorrhage, the patient presents with neck rigidity. That is also the patient complains of worst headache of my life. That is the chief complaint of the patient. But here there was no neck rigidity and everything, so we can rule out them. When we talk about the other the visual symptoms, we can rule out the other retinopathies based on our history and physical examination, and also the ophthalmologic examination. So based on the findings that we have, we can narrow down our diagnosis to four main differentials, that is gestational hypertension, preeclampsia, chronic hypertension, and superimposed preeclampsia. Now, the age of presentation is very important. Remember that whenever any hypertension presents after 20 weeks of gestation, it is usually that too whenever it is whenever it is not existing before pregnancy or in the first trimester, it is usually not chronic hypertension. So remember that we will come to the different diagnostic clues to this hypertension and its four main differentials in the later part of the this lecture discussion. So now these are basically a differential diagnosis. All right. So this is very, very important. So we can narrow down our differentials to four main subtypes, that is gestational hypertension, preeclampsia, chronic hypertension, and superimposed preeclampsia. All right. So based on this, the diagnosis of our patient is gravida 1, para 0, with no full term, preterm abortions or live births. Okay, G1, P0, pregnancy intrauterine with single live healthy fetus at 33 weeks and 0 days of gestation, in longitudinal live with cephalic presentation, not in labor, complicated by preeclampsia with severe features. So our diagnosis is preeclampsia with severe features. Now, how did I diagnose this patient? This patient only had hypertension. There is no proteinuria. How come I have diagnosed this patient to be a case of preeclampsia with severe features? So let's talk about it. So for that, we need to understand the classification of hypertension in pregnancy in depth. And to understand hypertension in pregnancy, remember that preeclampsia is a major cause of maternal and perinatal mortality and morbidity, which was the first thing that I told at the beginning of this class. Hypertensive disorders of pregnancy occur in about 10% of all the pregnant women around the world. Preeclampsia affects 3 to 5% of pregnancies. In Asia and Africa, nearly 1/10 of all the maternal deaths are associated with hypertensive disorders of pregnancy. So you can imagine the burden of the maternal mortality, which is resting on the shoulders of hypertension. And that is why this topic is very, very important if we are targeting to decrease the maternal mortality and morbidity rates. In India, the incidence of preeclampsia is reported to be 8 to 10% among the pregnant women. So to understand the pathophysiology of preeclampsia, understanding of the placentation is very, very important. As you can see that there has been this beautiful picture which shows that in a non-pregnant female, there are presence of the cytotrophoblastic cells which invade the spiral arteries. So in a non-pregnant female, the spiral arteries are totally coiled. All right. Whenever a patient becomes pregnant, in case of normal pregnancy, there is invasion of the spiral arteries by the cytotrophoblastic cells of the placenta, which will lead to conversion of low caliber vascular structure, vascular spiral artery into a high caliber, low resistant spiral artery vessel. So basically a spiral arteriole which was low caliber and high resistance in nature before pregnancy in a non-pregnant state now has become a high caliber, low resistant vessel. Okay, so this is in case of normal pregnancy. But in case of preeclampsia, this placentation and invasion of spiral arterioles is defective. It is not complete. So there is incomplete invasion of spiral arterioles, which make this still a high resistance, low caliber vessel compared to normal pregnancy. So because of this, there is a high resistance to the blood flow and less blood going to the fetus. That is why fetus is more at risk of having restricted growth, leading to fetal growth restriction or IUGR, intrauterine growth restriction. And because of the high resistance of the blood vessel, mother is at high risk of developing preeclampsia, eclampsia, chronic hypertension, or superimposed preeclampsia. So there is a defective placentation, which is the cornerstone of the pathophysiology of preeclampsia. Defective placentation. Write it in box, which is the cornerstone in the pathophysiology of preeclampsia. So now, because of this, it can lead to varied symptoms. Remember that there is an end organ damage. Remember that preeclampsia causes end organ damage. So, because of that, every organ system is affected. It can lead to variety of symptoms, starting with the elevated blood pressure, proteinuria, weight gain and edema, water retention, swelling, that is edema, right? Weight gain, edema, headaches, changes in the vision, nausea, vomiting, pain in the abdomen, back pain, and there can be hemolysis or breakdown of RBCs and complications of liver. So virtually every organ system in the body can be affected by this preeclampsia. That is why it can give rise to a varied presentation. Not all the patients in preeclampsia present with hypertension and proteinuria. There are other organs which can be damaged, and that is why there has been a drastic change in the definition and the terminology of preeclampsia. So, based on this, classification of hypertensive disorders in pregnancy is subdivided into 5 main classes. The first class is gestational hypertension. Second is preeclampsia and eclampsia. Then comes preeclampsia superimposed on chronic hypertension, and there is chronic hypertension in pregnancy. So, a pregnancy which was pre-existing, that is pre-existing hypertension, is known as chronic hypertension in pregnancy. So what is the definition of them? Remember that any new onset hypertension that is more than or equal to 140 or 90 after 20 weeks of gestation and proteinuria or end organ damage is considered to be a case of preeclampsia syndrome. Any new onset hypertension more than or equal to 140 over 90 after 20 weeks of gestation without proteinuria or other preeclampsia findings is considered as gestational hypertension. So gestational hypertension is only hypertension without proteinuria or any other symptoms of end organ dysfunction. Chronic hypertension is hypertension that precedes pregnancy or develops after 20 weeks of gestation. And chronic hypertension with superimposed preeclampsia is chronic hypertension with preeclampsia, in which there is new onset proteinuria or other features of end organ dysfunction. So this is basically the classification of hypertensive disorders of pregnancy. So in ACO in 2020, that is in June 2020, ACOG, that is American College of Obstetrics and Gynecology, has come up with an updated and a new update in the criteria of diagnosis of preeclampsia. So ACOG 2020 is the recent update for the diagnostic criteria for preeclampsia. So according to this, preeclampsia is defined as hypertension plus proteinuria or severe features. So the two things are prerequisite for this criteria. There must be presence of hypertension for sure. And in the second criteria, either there can be proteinuria or severe features of end organ dysfunction. All right. Remember that these severe features are markers of end organ injury. Okay. So new onset hypertension is prerequisite with either proteinuria or severe features. So this is the new update. So how do we define hypertension here? Hypertension is usually the onset after 20 weeks of gestation. Systolic blood pressure more than or equal to 140 and or diastolic blood pressure more than or equal to 90 millimeters of mercury. Sustain 2 resting measurements more than or equal to 4 hours apart is very, very important. Right? So it should be 2 readings, 140 over 90, and after 20 weeks. So our patient is at 33 weeks of gestation. She has 2 readings, which are more than 140 by 90, or at 4 hours apart. All right. Now, proteinuria should be measured either by 24-hour protein levels more than or equal to 300 milligrams is considered as proteinuria, or protein to creatinine ratio can be measured in spot sample, which should be more than or equal to 0.3. In our patient, it was 0.1. So that is why protein to creatinine ratio was normal. And dipstick should be more than or equal to 2+. This has been a new update. In the previous criteria, the dipstick reading was more than or equal to 1 plus for diagnosis of proteinuria in case of preeclampsia. But now in ACOG 2020, they have changed this dipstick finding and made it more than or equal to 2 plus. All right. So remember that dipstick in our patient was also traced. So our patient had no proteinuria. Now coming to the severe features, were there any features of end organ injury? Okay, but for that we need to know what are the markers of end organ injury. So the following are the markers of end organ injury. Thrombocytopenia less than 1 lakh, impaired liver function test, new development of renal insufficiency, that is creatinine more than or equal to 1.1 milligram per deciliter, pulmonary edema, new onset cerebral headaches, and visual disturbances. Yes, our patient had headaches and visual disturbances. All right. So now let us talk about two different types of preeclampsia. According to the ACOG 2020, there are two types of preeclampsia. One is preeclampsia without severe features, and another is preeclampsia with severe features. All right. In preeclampsia without severe features, what are the findings? Whenever a patient is having blood pressure of 140/90 on more than or equal to 2 occasions at least 4 hours apart after 20 weeks of gestation, it is considered as a case of hypertension. Or this patient may have a single blood pressure finding of more than or equal to 166 millimeters of mercury, or diastolic blood pressure more than or equal to 110 millimeters of mercury. This can be confirmed within short interval to facilitate timely, timely antihypertensive therapy. So whenever a patient having 140/90 blood pressure or severe range blood pressure, that is more than or equal to 166/110 millimeters of mercury, plus proteinuria, this is considered as preeclampsia without severe features. Proteinuria, we have already discussed what are the criteria used, right? Another type of preeclampsia is preeclampsia with severe features. For preeclampsia with severe features, this patient must have severe range of blood pressure, that is more than or equal to 160/110 on 2 occasions. Okay, on 2 occasions at least 4 hours apart, or unless the treatment has been started previously. All right, on 2 occasions at least 4 hours apart, unless an antihypertensive has been immediately started, or patient was already taking antihypertensive and still having this severe range of blood pressure, 160/110 millimeters of mercury, then it is considered as severe range of hypertension with severe features, like with other severe features like thrombocytopenia, impaired liver function, abnormal renal function test, pulmonary edema, cerebral and visual disturbances, right? Cerebral symptoms and visual symptoms. If any of this feature is present, if any one of the following features present, severe range blood pressure or any of the markers of end organ injury, this patient is considered to be a case of preeclampsia with severe features. All right. So any one of the following finding is required to label the patient as preeclampsia with severe features. So what was our case? In our case, the patient had blood pressure of only 140/90 on 2 occasions, but there was presence of visual disturbances and headaches, which are markers of end organ injury, and hence our diagnosis is preeclampsia with severe features. Okay, so our diagnosis is preeclampsia with severe features. So now how are you going to manage this case? Whether you are a 3rd year or 4th year MBBS student, whether you are an intern or a post-intern appearing for your NEET PG exam or FMG exam or any other exam in the world, you will always be asked this question: how are you going to manage this case? Because after diagnosis always comes the management part, which is the most important part. To be a good clinician, an accurate diagnosis is very, very important. And as important is its management, because if you can diagnose it correctly, only then can you manage the patient correctly. All right. So now coming to a major important part. For any exam which you will be appearing in the near future, there are certain questions which can be asked based on this kind of clinical scenario. So what are those cases? The first question is, are you going to manage this patient at home or are you going to admit the patient? So are you going to admit the patient or not? Will you give this patient inpatient or outpatient management? Next question, what should be your initial treatment? What are the choice of drugs that will be given to the patient? How are you going to deliver the patient? Are you going to deliver the patient by some, or you are going to expectantly manage the patient? So expectant versus delivery. Third question is, fifth question is, what kind of surveillance are you going to do for the patient? What time are you going to deliver this patient? Time of delivery and what mode of delivery will be preferred. All right. So I'll answer all your questions in a very step-by-step manner. First question. If you are an intern, I'll be asking you this question. Shall we admit this patient or should we admit this, should we manage it on an outpatient basis? I would be very happy if you answer me that, ma'am, we are going to admit this patient. Why? Because remember that the diagnosis of our cases, preeclampsia with severe features. All right. Preeclampsia with severe features are signs of impending eclampsia if we do not manage them, and it can lead to severe maternal and fetal sequelae if not treated them. And close observation and monitoring is very, very important, and that is why we will admit this patient. All right, so this patient will be offered inpatient management. What should the initial treatment of this patient be? Remember that the hypertension is severe and there are signs of imminent eclampsia, right? Preeclampsia with severe features is at risk factor of developing imminent eclampsia. So we will be giving this patient intravenous magnesium sulfate and also we will offer this patient pharmacologic treatment with antihypertensive drugs. Then the third question will be, what are the choice of drugs that will be given to this patient? The choice of the drugs are, we have basically three different types of antihypertensive, or rather I must say three different classes of antihypertensives. The first class is the beta blockers, that is labetalol, which is actually a combination of both the alpha and beta blocker. Remember that the first line or the drug of choice for hypertension in pregnancy is labetalol, whether it is for an acute or for chronic management, meaning to say whether it is an acute hypertensive crisis or for the maintenance of hypertension, it is labetalol is the drug of choice. All right. The second that we have is the calcium channel blockers like nifedipine. And we have the third class of drug is centrally acting alpha methyl dopa. These are all the different types of drugs that we have, right? Now, my question is, after controlling the blood pressure, when do we, okay, the first question would be, when do you say that the blood pressure is optimally controlled? If you are my intern, my student, I'd be asking this question. When would you say that you will optimally control the blood pressure? Remember that in hypertension, and if you answer me that if the blood pressure is less than 110 or less than 70, that is an optimal control, I would say no. Why? Because the ultimate aim or the target of our antihypertensive therapy is not to decrease the blood pressure by like around 120 or 80, not to normalize the blood pressure. The aim of our therapy, antihypertensive therapy, is to maintain a blood pressure of around 135 by 85 millimeters of mercury, and this is recommended by the latest NICE guidelines, which has come up in 2020. All right. So latest NICE guidelines of 2019-2020, they have come up with the target blood pressure goal in hypertension in pregnancy is 135 by 85 millimeters of mercury. So whenever the blood pressure is in that range, we can say that we have optimally controlled the blood pressure of the patient. Now what? Now what to do? What is the definitive treatment for preeclampsia with severe features? Remember that preeclampsia has only one definitive treatment, and that is delivery. All right. So, but for our case, what is the age of gestation of the patient? 33 weeks and 0 days. So what are we going to do? Are we going to manage the patient expectantly versus delivery? This is a next question. Should we manage this patient expectantly, or we must deliver the patient? Now, this is a very, very tricky question. Why? Because the time of delivery in case of preeclampsia with severe features is recommended at or after 34 weeks. If the mother and the fetus is stable, if the maternal and fetal parameters permit that, right? But in our case, after adequately controlling the blood pressure, if the maternal and fetal parameters are well controlled, then this patient can be expectantly managed for 1 more week and be terminated at 34 weeks. Why? Because the fetal lungs are immature at this gestational age. So this expectant management will permit us giving her a dose of corticosteroids also. All right, so we will give her a dose of corticosteroids that will enhance the fetal lung maturity. That is why this patient must be managed expectantly for at least 1 week. Okay, unless the maternal and fetal parameters are normal. If there is any problem with the maternal and fetal parameters, immediate delivery at any point of time must be done. All right. So surveillance is very, very important. And what should be the mode of delivery? The mode of delivery in any case of hypertension in pregnancy is always vaginal delivery. But at an early gestational age, like 34 weeks or 33, 34 weeks, there are high chances of failure of vaginal delivery. Okay, so, high chances of failure of induction and high chances of failure of vaginal delivery. So in those conditions, when there is a poor Bishop's score or whenever the vaginal delivery does not seem to be imminent, in those conditions, cesarean section is done. All right, so now I will tell how we had managed this patient. So this patient, before that, we will discuss the management of preeclampsia with severe features. So first of all, admit this patient to labor and delivery room for close observation of vital signs, symptoms, and fetal heartbeat. Second is give her a dose of intravenous magnesium sulfate prophylaxis. This is seizure prophylaxis, right? And intravenous antihypertensive drugs, okay, for rapidly controlling the blood pressure. Obtain the laboratory tests, ultrasound for estimated fetal weight and fluid, amniotic fluid index, deepest vertical pocket, and umbilical artery Doppler if there is presence of IUGR or FGR, fetal growth restriction. Corticosteroid if the gestational age is less than 34 weeks, and recently it has said if it is less than around 36 plus 6 days, right? So recently they have said that if the gestational age is even lesser than 36, we can give it, right? So, but in this case, definitely it should be given, and stable maternal and fetal conditions. Are there any indications of prompt delivery? Next question is, what are the indications of prompt delivery? Whether there is presence of any eclampsia, stroke, liver bleeding, whether there is presence of a non-viable fetus that less than around 23, 24 weeks, or the fetus is more than or equal to 34 weeks, fetal death. Remember that whenever a fetus is more than or equal to 34 weeks, definitely it should be undergo prompt delivery. Why? Because the definitive treatment of preeclampsia is delivery. All right. So whatever was the pathophysiology, it was a poor placentation in pregnancy which led to the entire pathophysiology of preeclampsia. Whatever was the pathophysiology, we just reverse it back. So ultimately, delivery is an ultimate solution for it. All right. So more than or equal to 34 weeks must definitely undergo prompt delivery. No need to wait further. If there is fetal death, that means it is already a severe grade of preeclampsia, and that is why this patient must be immediately delivered. Non-reassuring fetal heart rate. Remember that whenever we are doing the surveillance, CTG, that is cardiotopography, is very, very important because it will give us an assurance whether the fetal heart rate is reassuring, whether there are any signs of acute hypoxia in fetus or not. But if there is presence of non-reassuring fetal heart rate, biophysical profile of less than or equal to 2, serum creatinine more than or equal to 1.5 milligram per deciliter, or disseminated coagulopathy, meaning to say whenever there is a worsening renal function, DIC, abruptio placentia or pulmonary edema, all of these are the dreaded complications of preeclampsia. In these conditions, promptly stabilize the mother, and as soon as the maternal condition is stable, take her to OT, deliver the patient, right? Because these are the indications of prompt delivery. And there should be close monitoring, not only during delivery, but also after delivery of this patient, right? But if there are no such indications of prompt delivery, then ask the patient, look for the maternal, look for the entire medical profile of the patient, look whether there is a persistence of any symptoms, uncontrolled hypertension, HELP syndrome, FGR, fetal growth restriction, poor biophysical profile of the fetus, recurrent decelerations, minimal variability, labor or preterm rupture of membranes. In all this condition also, delivery must be done within 48 hours. All right. If we have these conditions, delivery must be done within 48 hours. All right. And if still such complications are not present, expectant management can be continued for 34 weeks, at least until the fetus reaches at a gestational age of 34 weeks and 0 days. Okay. And close maternal and fetal monitoring must be done, and then deliver the patient, so that both the maternal as well as fetal outcome will be good. All right. Because our ultimate aim is that both the mother and the baby must be in good and healthy condition. Okay. The ultimate aim of an obstetrician is not only about thinking of the baby, but the mother first, right? Because it is the responsibility, it is actually on an obstetrician's burden to take care of both the lives, right? Because if you look at any other branch of medicine, this burden, there is only a headache of one life. But it is this special branch of obstetrics and gynecology in which you can not only save one life, but you can save 2 lives or even more, right? So remember that this branch is very beautiful, in which both the mother and the baby must be taken care of. And that is why the optimal age of gestation to deliver in this case is 34 weeks. All right. So how did we manage our case? Seizure prophylaxis with IV magnesium sulfate was immediately given. Yes, remember that seizure prophylaxis is very, very important. Okay, because these are also signs of imminent eclampsia. Blood pressure was optimally controlled using first with IV labetalol, and then it was optimally controlled using oral labetalol 200 milligram twice a day. So it was maintained properly. And this patient, corticosteroids were given to induce fetal lung maturity. Expectant management was done till 34 weeks and 0 days of gestation. Maternal and fetal parameters were monitored and were all found to be normal. Cesarean section was done at 34 weeks of gestation, 34 weeks and 0 days of gestation. It resulted in a healthy live baby with good APGAR score with uneventful neonatal course. This is very, very important, uneventful neonatal course, right? This is very, very important. Blood pressure was returned to normal on 3rd post-operative day. Patient was discharged home on the 5th post-operative day, and counseling for the future pregnancies was done. Remember that any patient with presenting with preeclampsia or hypertension or any other kind of hypertension in pregnancy is at increased risk of developing hypertension in her subsequent pregnancies, as well as this patient is at risk of developing stroke and CVD risk factors, other CVD risks in future life. So this patient must be very, very well counseled about her future pregnancies and also developing hypertension and other risk, CVD risk factors and stroke in her later life. Okay, so this is very, very important. So our ultimate mission of our entire discussing our entire today's case is that every preeclamptic must become a survivor. Okay, because it is responsible for around 10% of maternal deaths and mortality, and around 1/10 of the maternal deaths and mortality in Asia and Africa. Our ultimate aim is that preeclamptics must be survivors. I want my doctors, all of you, to save every woman of preeclampsia from the dreaded complications of preeclampsia, and to decrease and reduce the maternal mortality and morbidity. And so that there may be so many babies in the world who can get the love of the mother, right? So our ultimate mission is preeclampsia must become a survivor. So this is our mission for today. Thank you all for your patient listening. And this is Dr. Vaidehi Desai Shah. I thank all of you on behalf of Dr. Bhatia's Medical Coaching Institute and eGurukul, the Inspired Learning app. Thank you for your patient listening, and good luck. Stay tuned and wish you all the best for your exams. Thank you.